Good morning, everybody. Today we are going to discuss about pediatric asthma. I am Dr. A. Agila, Assistant Professor, Department of Pediatrics, working in Sri Lakshminarayana Institute of Medical Sciences. So, what is pediatric asthma? Asthma is the most common chronic disease of childhood, and it is the leading cause of childhood morbidity from chronic disease as measured by school absences, emergency department visits, and hospitalizations. Asthma leads to recurrent episodes of wheezing, breathlessness, chest tightness, and coughing, particularly at night or early morning. Clinical symptoms in children 5 years and younger are variable and non-specific. Widespread, variable, and often reversible airflow limitation is a hallmark of asthma. So basically, asthma is because of airway hyperreactivity. So there's going to be a reversible airflow limitation in these children. So asthma, inflammation, and cell mediators. So there is an allergen. This allergen can be dust or mite or pollen or any known allergen causing asthma. Now, this allergen will go and activate the macrophage of the dendritic cell or the mast cell. This dendritic cell will activate the T helper cell too. And then the mast cell will activate eosinophils and neutrophils. And all this inflammation will cause mucus plug. It will cause mucus hypersecretion or hyperplasia. There will be vasodilation, new blood vessel formation, which is known as angiogenesis. And there will be plasma leak and edema. There will be subepithelial fibrosis, sensory nerve activation, cholinergic reflex, which now leads to bronchoconstriction, hypertrophy, and hyperplasia. This cholinergic reflex mainly acts on the airway smooth muscle, and this will cause bronchoconstriction. Now, what is the mechanism of asthma inflammation? So basically, there is a airway hyperresponsiveness. So any allergen or a sensitizer or a virus or an air pollutant, this will lead to inflammation. This is known as chronic eosinophilic bronchitis. This will lead to airway hyperresponsiveness, and that will produce symptoms. This airway hyperresponsiveness has got numerous triggers like allergen, exercise, cold air, sulfurs, or particulate matter. And everything together now will cause symptoms in asthma, which is cough, wheeze, chest tightness, and dyspnea. Now, how is the inflammation of asthma mediated? It can be mediated by inflammatory cells, structural cells. Then these cells will produce inflammatory mediators, and the mediators will have effect on the bronchus. So, what are the inflammatory cells which are leading to asthma inflammation? First is mast cells, eosinophils, T helper 2 cells, basophils, neutrophils, and platelets. There will be structural cells like epithelial cells, smooth muscle cells, endothelial cells, fibroblasts, and nerves. Now, these inflammatory cells will produce inflammatory mediators. What are the mediators that are produced? Histamine, leukotrienes, prostanoids, platelet activating factor, kinins, adenosine, endothelin, nitric oxide, cytokines, chemokines, and growth factors. And this will lead to bronchospasm, plasma exudation, mucus secretion, airway hyperreactivity, and structural changes. Factors influencing the development and expression of asthma. Now you have host factors, environmental factors. Host factors is mainly genetic. The person or the child is genetically predisposed to hyperreactivity, which is known as atopy. So genes that are predisposing to atopy and genes predisposing to airway hyperresponsiveness. Other host factors which can lead to asthma is obesity and sex of the child. Environmental factors. It's mainly allergens. These allergens can be grouped into indoor allergens and outdoor allergens. Indoor allergens can be domestic mice, furred animals like dogs, cats, and mice, cockroach allergens, fungi, molds, and yeast. Outdoor allergens are mainly pollens, fungi, mold, and yeast. Infection can also be one of the triggering factors for asthma. It is mainly predominantly viral infection. Occupational sensitizers like the industrial smoke, this can be a triggering factor. Tobacco smoke is a very important trigger for asthma. It could be passive smoking or active smoking. Indoor and outdoor air pollution and diet. These are the environmental factors which can trigger asthma. Risk factors for asthma in younger children. Sensitization to allergen. Maternal diet during pregnancy or lactation is known to have some risk factor associated with asthma. Pollutants, particularly environmental tobacco smoke, microbes and their products, respiratory viral infections, and psychosocial factors. These are the risk factors for asthma in younger children. So the prevalence of childhood asthma has continued to increase on the Indian subcontinent over the past 10 years. So what are the issues in pediatric asthma? So we have numerous issues. One is because it is underdiagnosed or misdiagnosed, acceptance of asthma diagnosis or the label of asthma, heterogeneous disease or varying phenotypes, cough or wheeze, poor patient or parent education, lack of knowledge and time versus more patients, oral versus inhaled therapy, choice of right device, heavy nebulization, fear of steroids. So these are the issues in pediatric asthma. What are the other challenges? Most of the children who are below than 5 years of age cannot tell their problems. Parents are proxy storytellers who may mislead the doctor. Pulmonary ejection flow cannot be performed in children below 5 years of age. And fear of addiction to inhalation therapy is there. Physicians lack knowledge and time. So what are clinical features of asthma? First, it is recurrent wheeze, recurrent cough, recurrent breathlessness, activity-induced cough or wheeze, nocturnal cough or breathlessness, and tightness of the chest. Symptomatology. Cough is present in 90% cases, wheezing in 74%, and exercise-induced wheeze or cough in 55%. What are the atypical features of asthma? Afebrile episodes, personal atopy, family history of atopy or asthma, exercise or activity-induced symptoms, history of triggers, seasonal exacerbations, and relief with bronchodilators. These are the typical features of asthma. When does asthma begin? By 5 years, only in 26% cases. 1 to 5 years is where the major chunk, half the babies develop, 51% will develop asthma between 1 to 5 years. And after 5 years, again, only 22%. So now 77% of asthma begins in children less than 5 years of age. So what are the tools to diagnosis? Good history taking by asking, careful physical examination is looking, and performing is investigations only above 5 years of age. What do you ask? In history taking, your symptoms should be, has the child had an attack or recurrent episode of wheezing, high-pitched whistling sounds when breathing out? Does the child have a troublesome cough, which is particularly worse at night or on waking? Is the child awakened by the cough or difficult breathing? Does the child cough or wheeze after physical exercise, like games or exercise, or excessive crying? Does the child experience breathing problems during a particular season? Now, these are the questions which you will be asking carefully to know whether the history is consistent with asthma. If the answer is yes to any of these questions, a diagnosis of asthma should be considered. Now, what will you look in physical examination? General attitude and well-being, any deformity in the chest, what is the character of breathing, thorough auscultation of breath sounds, signs of any allergic disorders on the body, growth and developmental status. So these are the things you have to look carefully in a physical examination. What all features one should look for specifically? Now, what about dyspnea? During dyspnea, you have to look for expiratory wheeze, accessory muscle movement, difficulty in feeding, talking, and getting to sleep, and irritability. Cough, whether it is persistent or recurrent or nocturnal cough or an exercise-induced cough. Associated conditions, please look for other features of atopy like eczema and allergic rhinitis. You also have to assess the development and weight and the growth of the child. Please assess the weight and height of the child correctly. What all investigations can be performed in asthmatic children? First is your peak expiratory flow rate. It is highly suggestive of asthma when more than 15% increase in peak expiratory flow rate after a inhaled short-acting beta-2 agonist, or a more than 15% decrease in peak expiratory flow rate after exercise. Diurnal variation of more than 10% in children not on bronchodilators. So these are the features suggestive of asthma. The early wheezer, when a child is having a wheezing trouble less than 3 years of age. It can be either of the two things. It could be a wheeze-associated lower respiratory infection or a viral-associated wheeze, or it could be a early onset asthma. Waldry or wheeze-associated lower respiratory tract infection is mainly febrile episode. Personal atopy will be absent. Family history of asthma or atopy is absent, and variable response to bronchodilators. Early onset asthma will have afebrile episodes. Personal atopy is present. Family history of asthma or atopy is present, and predictable good response to bronchodilators. These are the features which are going to differentiate the two causes of early wheezer, which is Waldry and early onset asthma. Bronchiolitis in children. It's the commonest cause of wheezing in children between 6 months to 3 years of age. It will resemble asthma. Diagnosis is essentially clinical. Common viruses causing bronchiolitis in children is respiratory syncytial virus. Clinical manifestations of RSV disease is mainly rhinorrhea, pharyngitis, cough, low-grade fever, wheezing, and increased respiratory rate. Differential diagnosis. Less than 6 months, a common differential diagnosis of asthma or of wheezing is basically bronchiolitis and gastroesophageal reflux. Uncommonly can have aspiration pneumonia, bronchopulmonary dysplasia, congestive heart failure, and cystic fibrosis. Rarely it is only asthma and foreign body aspiration. 6 months to 2 years, more common cause of wheezing is bronchiolitis and foreign body aspiration. Uncommon causes are aspiration pneumonia, asthma, bronchopulmonary dysplasia, cystic fibrosis, and gastroesophageal reflux. Rare causes congestive heart failure. 2 to 5 years, common differential diagnosis of wheezing is asthma and foreign body aspiration. Uncommon is cystic fibrosis, gastroesophageal reflux, and viral pneumonia. Rare cause of wheezing is aspiration pneumonia, bronchiolitis, congestive heart failure. Identifying the comorbidities. Comorbid conditions of asthma can be allergic rhinitis, where they'll have frequent colds and ear infection, sneezing in the morning, blocked nose, snoring, and mouth breathing. Gastroesophageal reflux can have nocturnal cough followed by vomiting, and also eczema. Guidelines for confirming childhood asthma diagnosis. The IPAC diagnosis is characterize the problem, establish the chronicity, exclude non-respiratory or other causes, exclude infectious diseases, consider the patient's age and use diagnostic aids. Early childhood asthma diagnosis below the age of 6 years. So, the diagnosis of asthma in children under the age of 6 is primarily one of exclusion. Physical examination. If the child does not appear acutely ill and is growing, and there is no evidence specifically indicating another cause of symptoms, a trial of therapy is warranted. Trial of therapy with bronchodilators. Improvement with treatment supports a diagnosis of asthma. Frequent reassessment. Healthcare professionals should always be prepared to reconsider the diagnosis if management is not helping the child. So childhood asthma diagnosis, 6 to 14 years, we have a childhood asthma questionnaire, which has got these questions. Has you or your child had wheezing or whistling in the chest in the last 12 months? In the last 12 months, have you or has your child had a dry cough at night? Apart from cough associated with cold or a chest infection, do you or does your child have a history of hay fever or eczema? Is there a family history of asthma in your child's first degree relative? Have you or has your child received more than 3 courses of antibiotics for respiratory symptoms, both upper and lower respiratory tract infection in the last 12 months? In the last 12 months, has your child's or your chest sounded wheezy during or after exercise? In the last 12 months, has your child's sleep or your sleep been disturbed due to wheezing? In the last 12 months, has your wheezing ever been severe enough to limit your child's or your speech to only 1 or 2 words at a time between breaths? In the last 12 months, has your child been to doctor, an emergency room, or a hospital for wheezing? Diagnostic tools and the findings that support diagnosis. In physical examination, expiratory wheeze and auscultation may or may not be present. Increased respiratory expiratory time may or may not be present. Reversibility testing with spirometry or peak expiratory flow. Demonstration of reversible airflow limitation. FEV1 improves at least 12% either spontaneously or after an inhaled bronchodilator or after a trial of glucocorticosteroid therapy, or a peak expiratory flow that improves at least 15% after inhaled bronchodilator or a trial of glucocorticosteroid therapy. Exercise challenge with spirometry or peak expiratory flow. Demonstration of airway hyperresponsiveness. FEV decreases by at least 15% from baseline after 6 minutes of exercise, or the peak expiratory flow decreases at least 20% from baseline after 6 minutes of exercise. Some children with asthma present only with symptoms associated with exercise. Home peak expiratory flow diary. Demonstration of variable airflow limitation. Peak expiratory flow varies more than 20% from morning measurement upon arising to measurement 12 hours later in patients taking bronchodilator, more than 10% in patients not taking bronchodilator. Trial of therapy. Improvement with bronchodilators or with trial of inhaled glucocorticoid therapy. Allergy skin testing or measurement of allergen-specific IgE in serum can confirm the presence of atopy, and specific triggers also can be identified. Nordic census. Confirm asthma if the child is having 3 attacks of airway obstruction in the last 1 year. If the child gets 1 attack of asthmatic symptoms after the age of 2 years, irrespective of the child in an attack in child with allergy or history of atopy. If the child does not become free of symptoms when infection has ceased or has persistent symptoms for more than a month. IAP guidelines. 3 or more episodes of airflow obstruction with several of the following: afebrile episodes, personal atopy or family history of atopy or asthma, nocturnal exacerbations, exercise or activity-induced symptoms, trigger-induced symptoms, seasonal exacerbations, relief with bronchodilators plus or minus oral steroids. GINA guidelines. The following symptoms are highly suggestive or diagnosed for asthma: activity-induced cough or wheeze, nocturnal cough in periods without viral infections, absence of seasonal variation in cough, symptoms that persist after the age of 3, a simple clinical index based on presence of wheeze before the age of 3, presence of 1 major risk factor like a parental history of asthma or eczema, or 2 to 3 minor risk factors, eosinophilia, wheezing without colds, allergic rhinitis, has been shown to predict the presence of asthma in later childhood. Children 5 years or younger in a trial treatment with short-acting bronchodilators and inhaled corticosteroids. Children 4 to 5 years of old can be taught to use a peak expiratory flow meter, but to ensure reliability, parental supervision is usually required. Use of spirometry and other measures are recommended for older children, such as airway hyperresponsiveness and markers of airway inflammation is difficult, and several require complex equipment, making them unsuitable for routine use. The British Thoracic Society initial assessment of children suspect of having asthma should be based on presence of key features in the history and clinical examination and careful consideration of alternative diagnosis. Using a structured questionnaire may produce more standardized approach to the recording of presenting clinical features and the basis for a diagnosis of asthma. Clinical features that increase the probability of asthma: breathing, chest tightness, particularly if these symptoms are frequent and recurrent, worse at night or early in the morning, occur in response to or worse after exercise or other triggers such as exposure to pets, cold or damp air, or with emotions or laughter, occurs apart from colds, personal history of atopic disorder, family history of atopic disorder and or asthma, widespread wheeze heard on auscultation, history of improvement in symptoms or lung function in response to adequate therapy. Clinical features that lower the probability of asthma: symptoms with cold only or with no interval symptoms, isolated cough in the absence of wheeze or difficulty in breathing, history of moist cough, prominent dizziness, lightheadedness, and peripheral tingling, repeated normal physical examination of chest when symptomatic, normal peak expiratory flow or spirometry when symptomatic, no response to trial of asthma therapy, and clinical features pointing to alternative diagnosis. What are the asthma phenotypes? Preschool asthma phenotypes. Wheezing is common in young children, but is it asthma? So this is called as transient wheezers. They'll have more symptomatology between 2 to 3 years of age, and as they become older, their wheezing will reduce. These are called transient wheezers. These are non-atopic viral induced wheezers. They peak during 4 to 5 years of age, and the symptoms tend to reduce very gradually over the next 5 years, and after 11 to 12 years, the viral induced wheeze will reduce. Atopic asthma will start only after 3 to 4 years, and their propensity to develop asthma in response to atopy or in response to triggers is going to consistently increase. So these are the asthma phenotypes in childhood. Transient asthma is linked with smoking during pregnancy, viral RTIs not associated with atopy, remits by school age, and impaired lung function can be present at birth. Persistent asthma is not associated with atopy, associated with viral respiratory infections, may remit during school age, and leukotriene receptor antagonists have found to be beneficial. Associated with atopy, bronchial hyperresponsiveness will be there, impaired lung function will be there, parental history of asthma will be there, and it is mostly ongoing during school age. The goal of treatment is to achieve and maintain control for prolonged periods due to regard of safety of treatment, adverse effects, and cost of treatment required to achieve this goal. Assessment of asthma control should include control of clinical manifestations, control of expected future risk to patients such as exacerbations, accelerated decline in lung function, and side effects of the treatment. Achievement of good clinical control of asthma reduces the risk of exacerbations. So what is well-controlled asthma, partially controlled asthma, and uncontrolled asthma? So this is based on all of these parameters. Daytime symptoms will not be present in controlled asthma. Partly controlled asthma will be more than twice a week. Uncontrolled asthma will be 3 or more of the features of partly controlled asthma present in any week. Limitation of activity will not be present. It will be present. Nocturnal symptoms or awakening will not be present in controlled asthma. It can be present. Need for rescue or reliever therapy will not be there. Here will be more than twice a week. Lung function as measured by peak expiratory flow or a FEV1 will be normal, less than 80% predicted of personal best on any day. Exacerbations will not be there in controlled asthma. 1 or more exacerbation per week. Now, daytime symptoms like wheezing, coughing, and difficulty breathing will not be there. It will be typically more than twice a week. And it will be lasting for shorter periods on the order minutes and rapidly relieved by use of rapid-acting bronchodilators, partly controlled asthma. In uncontrolled asthma, it will be more than twice a week, typically last minutes of hour or recur, but partially or fully relieved with rapidly acting bronchodilators. Limitation of activity will not be there in controlled asthma. It can be present in partly controlled asthma. Nocturnal symptoms are another very important feature which differentiates the control. Need for reliever therapy, it will be less than 2 days a week. It will be more than 2 days a week in uncontrolled or partly controlled asthma. Now, asthma treatment. The asthma medicine can be classified into controller medications and reliever medications. Controller medications are medications which need to be taken on a daily long-term basis. And reliever medications are medications that we used as on a need basis to relieve the symptoms quickly. Now choosing the inhaler device. Less than 4 years, the preferred device is a pressured meter dose inhaler plus a dedicated spacer with face mask. Alternative device is a nebulizer with face mask. 4 to 5 years, it is a pressured meter dose inhaler plus dedicated spacer with mouthpiece, nebulizer with mouthpiece. Older than 6 years, you can use a dry powder inhaler or a breath actuated pressured meter dose inhaler or a pressured meter dose inhaler with spacer with mouthpiece. Alternative device is nebulizer with mouthpiece. Asthma management and prevention. The goals of successful management of asthma is to achieve and maintain control of symptoms, maintain normal activity levels including exercise, maintain pulmonary function as close to normal as possible, prevent asthma exacerbation, avoid adverse effects from asthma medications, and prevent asthma mortality. Now, we'll go to the management of asthma. This is management older than 5 years, adolescents and adults. Step 1 is as and when needed, rapidly acting beta-2 agonist, which is controller options. Step 2, you have to add a low-dose inhaled corticosteroid or a leukotriene modifier. Step 3, you can add a low-dose inhaled corticosteroid plus a long-term beta-2 agonist or a medium or high-dose inhaled corticosteroid or a low-dose corticosteroid plus leukotriene modifier or a low-dose inhaled corticosteroid plus a sustained-release theophylline. Medium or high-dose inhaled corticosteroid plus long-acting beta-2 agonist. At step 4, leukotriene modifier and sustained-release theophylline. And step 5, you can have a oral glucocorticosteroid and anti-IgE treatment. Inhaled medications are preferred because they deliver drug directly to the airways where they are needed, resulting in potent therapeutic effects with fewer systemic side effects. Inhaled medications for asthma are available as pressured meter dose inhalers, breath actuated meter dose inhalers, dry powder inhalers, and nebulizers. Spacer devices make inhalers easier to use and reduce systemic absorption and side effects of inhaled corticosteroids. Patients should be demonstrated about the use of these devices. And you have to monitor. What is the asthma management for less than 5 years of age? Controller on a need basis. Partly control or needed, you can have other controller options like low dose inhaled corticosteroid or leukotriene modifier. Uncontrolled, you can use a double low dose inhaled corticosteroid or low dose inhaled corticosteroid plus leukotriene modifier. To summarize, asthma is a diagnosis. The diagnosis of asthma is mainly based on clinical examination and relies on history. All asthma does not wheeze. In children less than 3 years, wheeze-associated lower respiratory infection is an important differential diagnosis. 2 out of 3 children will outgrow their asthma. A family history of asthma or atopy increases the risk of asthma. So I also want to discuss about the developing the patient-doctor relationship. So the 5 interrelated components of therapy that are required to achieve and maintain control of asthma is to develop a patient-partner relationship, identify and reduce exposure to risk factors, assess, treat and monitor asthma, manage asthma exacerbations and special considerations. Developing patient-doctor partnership. Effective management of asthma requires the development of partnership between the person with asthma and the healthcare team. Patients can learn to avoid risk factors and take medications correctly. Understand the difference between controller and reliever medications. Monitor the status using symptoms and if relevant, peak ejection flow, recognize signs of that asthma is worsening and take action, seek medical help as appropriate. Assess, treat, and monitor asthma. The goal of asthma treatment can be reached in most patients through a continuous cycle that involves assessing, treating, and monitoring asthma. Each patient should be assessed to establish his or her current treatment regimen, adherence to the current regimen, and the level of asthma control. Each patient is assigned to one of the 5 treatment steps. At each treatment step, reliever medication should be provided for quick relief of symptoms as and when needed. So this is what we saw. These are the 5 steps. Here, only reliever medication. Now here we are adding low dose inhaled corticosteroid or a leukotriene modifier. Then you are doing a low dose inhaled corticosteroid plus a long acting beta agonist, medium dose or a high dose inhaled corticosteroid. Add one more medium dose or a high dose ICS plus long acting beta agonist. Here you can again add oral glucocorticosteroid, lowest dose possible, and anti-IgE treatment. Now, how do you monitor? Monitoring is essential to maintaining control and establishing the lowest or the safest dose of treatment to minimize the cost and maximizing the safety. If asthma is not controlled, step up the treatment. Improvement is generally seen within 1 month. If asthma is partly controlled, consider stepping up treatment depending more effective options available, safety and cost of possible treatment, and patient satisfaction with the level of the control achieved. If control asthma is maintained for at least 3 months, you can step down with a gradual stepwise reduction in treatment. The goal is to decrease the treatment to at least to the least medication necessary to maintain control. Now this is a less than 5 years which we saw. Again, asthma education, environmental approach, and as needed rapid acting beta agonists are important. To summarize, I've already summarized. Diagnosis is mainly clinical, relies mostly on history, and 2 out of 3 children will outgrow their asthma. Family history of asthma or atopy increases the risk of asthma. Long-term management, patient education is a very important part of asthma management. Drugs control but do not cure asthma. Clinical grading over time decides long-term management plan. Mild intermittent asthma does not merit controllers. Inhaled steroids are the mainstay of long-term asthma management. Treatment should be stepped up or stepped down depending upon the patient's response. Thank you so much. I hope you've got a detailed understanding of asthma from this class. If you have any doubts, you can always contact me. Thank you for the opportunity. Thank you so much.